Good evening, everyone. I hope you can hear me. A warm welcome to the first Master Techniques webinar in 2024. The topic is very relevant to foot and ankle surgeons, especially who do trauma, and those who don't do trauma also see effects of ankle malunion and have to deal with it. I have pleasure that we have two elite speakers today who are going to talk about the malunion after ankle fractures. Before I invite our first speaker, unlike our previous webinars where we did it on Zoom, the webinar on Medal this time, the feedback and the certificate would be automatic. So you should receive a feedback form and hopefully you'll respond to it and you'll receive the certificate for attending the Master Techniques BOFAS webinar. So our first speaker is Nikolaos Gougoulias, a very good friend, a member of the education committee in IFAS, great educator, has done lots of publications. And Nikos is going to talk to us about syndesmotic malreduction, how to avoid in the first place, and if it happens, how to deal with it. Over to you, Nikos.
Thank you, Maneesh. I would like to thank you personally and BOFAS for giving me the opportunity to be here with you and for organizing this webinar again. So why is this a hot topic? Because unfortunately, we see pictures like this, and these patients end up like that very often. So the messages I would like to give to our audience is that we should get it right first time, so how to avoid these problems. And if we did not get it right, we should revise it as soon as possible. And of course, there will be people who say, well, this doesn't happen to me very often. But if you're honest with yourself and you audit your results, like our colleagues in the big trauma center in the north of England did, they found out that malunions around ankle fractures are so common, as well as complications. And once they started introducing the dedicated foot and ankle trauma list, which means these lists are being supervised by foot and ankle specialists, we could see that these complications are usually avoidable and mal reductions are not common anymore. So, and that reminds me of a case that presented back in 2008 when I was in Surrey doing my fellowship as a simple ankle sprain. And 6 weeks later, this patient presented into the fracture clinic seen by Matt Solon, the foot and ankle surgeon, in this condition. So what was not recognized initially is that there was a fracture, not in the ankle, but associated with an ankle injury, and that caused damage. There was damage to the deltoid ligament as well as the syndesmosis and the interosseous membrane. So sometimes what we see today are results of a bad surgical technique or of bad decision-making because we did not assess the injury properly. And let's go back to some basics, because some people in the audience might not be familiar with advanced knowledge in foot and ankle. So the distal tibiafibular syndesmosis is a very important joint. It's not immobile, it's a bit mobile, so it allows a little movement of the fibula so that the wider portion of the talus anteriorly can fit within the mortise when we dorsiflex the ankle. And so that motion is a bit of rotation and posterior to anterior translation of the fibula, and that is associated with proper function of the ligaments around the ankle. And we know from all the studies, and these findings have been confirmed with newer studies, that even a slight displacement of the talus within the mortise is responsible for a decrease in the contact area by about 40%, and that causes increased pressure in those areas, and that's the result of damage to the cartilage and development of arthritis in the longer term. So, and our ankle is subject to rotational injuries. And let's talk about these main mechanisms of injury described in the Lauge-Hansel classification. So the supination or pronation external rotation injury, and that refers to the position of the foot while the rest of the body rotates externally. And there is a different sequence of events. The supination external rotation injury, which the injury starts on the lateral side in the area of the syndesmosis and the lateral malleolus, whilst with the pronated foot, the injury starts medially, then goes to the lateral side, then it might break the fibula higher up, so the so-called Weber C fracture, and then it might go around the back to cause a posterior malleolus fracture or an injury at the back. And the ankle is a ring. So if a ring breaks in one place, it's still stable, it stays together. If it breaks in more than one place, it falls apart. And where does it break? So it can break in the malleoli, medial, lateral, posterior, or anterior, as I'm sure Stefan Rammelt will present to you later, or there can be a soft tissue equivalent to the bony injuries. And all these injuries affect what we call the distal tibiofibular syndesmosis. So let's look at this fracture. It's unstable, so there is evidence of injury to the deltoid ligament, but when it's subjected to weight bearing or when we put the foot plantigrade, it reduces. Whereas this fracture does not. And in the past with Anthony Sacchellari, we published this paper and said we thought that this is the result of the characteristics, the properties of the deep deltoid ligament. Because the deltoid ligament, coming from the Greek word delta because of its shape, at least in the superficial portion, is not one ligament. It consists of many ligaments, I would say. There is a superficial portion that bridges the talus, and there is a deep portion, which is the most important one, the posterior of the deep portion that stabilizes the talus within the mortise. And there are different characteristics of the different portions. So when the foot is plantigrade, the deep posterior portion of the deltoid holds the talus within the mortise stable. But over the years, we have realized that there is something else going on. What is the difference between these two types of fractures? The difference lies within the syndesmosis injury. On the fracture you see on the top, the syndesmosis was intact, whilst on the fracture at the bottom of your screen, the syndesmosis was injured. So that ring was now clearly broken into two places, and the syndesmosis was not intact. That's why the second fracture is more unstable, let's put it this way, than the first one. And these are the syndesmotic ligaments, three portions, anterior, posterior, and the interosseous, and we see to what extent they provide stability. So the posterior PITFL, posterior inferior tibiofibular ligament appears to be the strongest. So, and these are some anatomical specimens. The AITFL is what we see also on anterior ankle arthroscopy, while the PITFL is more difficult to assess only if you do posterior approaches to the ankle, as also shown here by the images of Pogolano. And what you can see on the CT image I've put up there is that the PITFL is attached to what we call the posterior malleolus, which is a projection of bone, really. What is the malleolus, really? And these avulsion affects the syndesmosis, as you can see, whilst on the anterior aspect of the tibia, a similar avulsion can occur. This is a quite large fragment here on this example I give you. Usually they're smaller, and that affects the syndesmosis as well. And why would we fix this injury anatomically? This actually would be for the ligaments to heal at the right length and tension, and for the syndesmosis and the whole of the ankle joint to work properly in the future. Sometimes the syndesmosis disruption is obvious and sometimes not so obvious, and therefore you need more advanced imaging to assess all aspects of the injury to your ankle, and that's the CT scan. And as you can see here, we have to think of the ligamental structures as well. As you can see, this fibula is not well aligned within the incisura. The ligaments might be intact, or sometimes they're injured, as well as at the same time with the bone. But it's the bony injury, the avulsion of the bony fragments, that causes the displacement of the fibula within the tibiofibular syndesmosis. And that appeared to be a simple, stable fracture. A bit later, there is some evidence there already on 6 weeks that there's something not right. It's opening up medially. There is something at the back of the ankle, the initial diagnosis was not right, and within a year and a little bit more, it ended up in this bad situation that was avoidable. So this is a little bit more obvious that this is a serious injury. And I would say, if you have a fracture dislocation, for me, always rings a bell. There is something strange and wrong here, and you have to be very careful. Because what happens is we use these ankles, and if you just rely on this X-ray, you would say, yes, this is not very bad, and that's what the colleagues saw. They fixed it, they did a hook test, and they interpreted this picture on your right as, well, not opening up on the medial side. One can disagree with this, and this fracture ended up like this already in 3 months' time. Now, we asked for a CT scan a bit late, I would say, and now we realize what was missed. So there was avulsion anteriorly and posteriorly, and this was the reason why the syndesmosis was not in the right place, even postoperatively. And this is not so rare. This is common, more common than you think, like in this case. So there is a little fragment there accompanying the fibula, and that's part of the posterior malleolus. And this is really small, so the surgeon said, well, I don't have to fix this little fragment. I just put syndesmosis screws to stabilize this. Well, the fixation of the fibula is not strong enough. The reduction, I don't know if it's good enough, and the fixation of the syndesmosis is probably not good enough. And the posterior malleolus was ignored, and that's how it ended up within 8 weeks from the injury. And the CT scan shows exactly the same than the last one I showed you. So this is not so uncommon. So get the CT scan in the first place, and that will reveal all the injuries, and then you decide what you do with those little fragments, or how you will reduce and stabilize the syndesmosis. And we have these two classifications, produced around at the same time, saying exactly the same. So I don't think that will be the start of a German-British debate, and I would say probably it would be the ancient Greeks who would have discovered this if they had the CT scan a few thousand years ago, but they didn't. So CT scan is important because it changes your management plan, and what we know is that the small posterior malleolar fractures affect the syndesmosis, and that's why they should be fixed. And also, if you fix the posterior malleolus directly, that produces very good syndesmosis stability, whilst if you rely on syndesmosis screws, that's not so good. And yes, a big fracture, you fix it to restore the tibial plafond, but even the small ones need fixing, I repeat it, to reduce the syndesmosis. A posterior malleolus fracture or an anterior malleolus fracture is equivalent to a syndesmosis injury. And as you can see, even a small displacement of this tiny fragment of the posterior malleolus affects the size of the syndesmosis and how the fibula sits with it, as this study shows. And of course, we should abandon this dogma from several decades ago that has no scientific validity. So what kind of fracture is this? What are we going to do with that? We don't know until we get a CT scan. And this is a fracture with a malaligned syndesmosis. And if you fix the bony fragments, this is what you have to do in order to get the fracture reduced, and that will reduce the syndesmosis. And do I need syndesmosis screws now? No, because I have reattached all the ligamentous avulsions back to the main bone, and they will heal at the right length and tension, and I can assess my syndesmosis through the posterior approach. Again, another unstable fracture. you fix the bony fragments anatomically, so do a total, not a partial open reduction internal fixation, and you don't need syndesmosis screws. Now, this is a high energy injury. Here we haven't got a broken medial malleolus. We have a fibular fracture, a posterior malleolar fracture that's equivalent to a syndesmosis injury, and the deltoid is gone for sure. Now, we fix the fractures. Do I need syndesmosis screws now? Well, previously, we had the ankle ring broken in several places, 3 places. Now, it's only the deltoid I haven't repaired. So by fixing the posterior malleolus, it is as if I have repaired the syndesmosis. So I don't need to repair the deltoid, and I don't need to put a syndesmosis screw if I fixed everything else. And these, of course, I tested intraoperatively, and I have checked the syndesmosis reduction under direct vision through my posterolateral approach in this case. Again, another injury, close injury, but a fracture dislocation, that rings a bell. It is nicely reduced. If you just look at the X-ray on your right, you will say, yes, that's not so bad. But remember, it's a high fibular fracture, Weber C pronation, external rotation injury that has disrupted the interosseous membrane as well. You get your CT scan with the ankle reduced. What do you do now? Just rely on your syndesmosis screws? Only fix the fibula and the posterior malleolus. Do you still need syndesmosis screws? All these are things you have to consider. Fixing the fractures, you do your checks, and as I said, we have turned an unstable ankle injury to a stable one. The interosseous membrane must have been damaged here. So this is debatable whether you should use a syndesmosis screws or not. So I wouldn't blame anyone for using a syndesmosis screw here. I haven't done so, and the patient had no problems. So by testing it intraoperatively with the hook test, but also with external rotation tests, make sure the syndesmosis is right. And it's not just me saying this, showing a couple of cases. There is a study also showing that fixing the posterior malleolus fracture reduces the need for syndesmosis screws. And for me, that's very important because syndesmosis screws are a source of many problems if you just rely on that. So when do I need syndesmosis screws despite I should fix the fracture? You have to consider whether you have fixed everything else and your ankle is stable, and you check it on the table. But the likelihood is that if you have fixed all the bony components, the need for syndesmosis screws might not be there. Fracture dislocation, so that ankle was reduced in the emergency department because it was the patient was in a lot of pain, and then an X-ray was taken. You have to consider the history of fracture dislocation because that rings a bell. That's a serious injury. Be careful. So no CT scan was done. The patient was taken into the operating theater relatively soon after the injury. Fibula is fixed. Medial side is still open. Now, Mr. Colleagues thought, well, if I reduce the syndesmosis with a clamp and position it there so the medial side closes, we put the screw and everything is held together. Now I can see that there is a little flake at the back, which might have been an avulsion of the posterior malleolus. And this is why, because I haven't fixed the posterior malleolus, this is why I needed the syndesmosis screw. And this patient did well with the syndesmosis screw in situ. So, but we have to be careful. If we miss the posterior malleolus, if we haven't done a CT scan, at least we have to bear in mind that the ankle might still be unstable. Similar case, fracture dislocation, ruptured deltoid. We did the hook test, but it's the external rotation test that shows the instability on the medial side, and the syndesmosis screw is essential in a case like this. And once the unstable injury is turned to a stable one can leave the deltoid ligament alone. I would personally not repair it in such case. And this is a nice example in a publication by Matt Solon and colleagues. So you see fracture dislocation, you see the tiny fragments of the front and the back of the ankle, avulsion of the PITFL and AITFL. So the fibula is brought out to length, fixed the Weber C fracture, and now what has been done is that the the AITFL has been reattached, the PITFL has not been. And the authors ask themselves, should one have fixed the PITFL, then we might not have needed the syndesmosis screw at all. However, I would say because the interosseous membrane is torn as well, it's not a bad thing to stabilize the syndesmosis with a screw as well in this case. So take home message from this: fix the fractures, total fixation, not partial fixation of the fractures around the ankle. That reattaches the ligaments, and that turns the unstable injury into a stable one. Even if you don't repair that deltoid, the ring is still stable, and that should be okay. Now, if you fix the syndesmosis, should you use screws or suture button? Well, looking at the literature, that's not the point. The point is, have you reduced the angle? Have you done anything else right? How many screws? Who knows? How big? Yes, how big should the screws be? 3 or 4 cortices? I would answer yes, 3 or 4 cortices. Does it matter if they break? Probably not. You take them out. I now do not plan to take the screws out unless they cause symptoms, so stiffness in young patients. And I have seen that I rarely have to go back. It's usually in young athletic people I would have to go back and remove the screws. I warn them that they might break, and that's not a problem as long as the ankle remains reduced. So, and you see all these publications, tightrope versus screws. I think this is not the point. So you see all sorts of, I would say also nonsense in the literature. That's not the point. And again, hybrid fixation, that confuses me. Why should I use a partially threaded screw to compress the syndesmosis? Is it a positioning or a compression screw? So I would say, would not focus on this subject because that's not the point. My point is try to avoid using syndesmosis screws, fixing the fractures properly. Like in this case, we haven't fixed the posterior malleolus, so your syndesmosis fixation, which is a little bit high as well, is weak, and that might cause problems, and you're not sure whether this syndesmosis is reduced. My advice is make sure you have reduced the syndesmosis before putting the screws in, and you put the screws in, I would say, in neutral position. How do you assess reduction? Arthroscopically or open through your surgical approaches. That's the best way to confirm. If you have an intraop CT scan, that's fine. That will give you the answer. But most people here have not an intraop CT scan. And do not miss the tibia or the fibula, because in this case, even the fibula was missed. It started like this. In the OR, the images were not really good, not assessed very well, and then you revise it. Even here, I would say, the fibula is slightly short and probably rotating because of the high fibular fracture, and there is a question, should we anatomically fix the fibula? Doesn't matter how high the fracture is. I haven't got the answer, but probably that's something to think about. Young patient, 17, he was supposed to have a stable Weber B supination external rotation type 2 injury. At 4 weeks, comes back for follow-up. Something doesn't look right. One does an X-ray of the other side, and there is a difference in the appearance of the syndesmosis. Whether these 2 X-rays are taken the same way, we don't know. What will give you the answer is the CT scan, and it clearly shows here that the fibula is too anteriorly in the incisura. So, an arthroscopic assessment of the joint found that there was an anterior syndesmosis, a syndesmosis injury, I would say. We cleared the scar tissue, and you can see here the position of the fibula. I have rotated the CT scan image anteriorly to the tibia, and once you put the clamp on the outside, you see the fibula sliding back in the correct place, and you can assess it like this, and you put the screws in the reduced position, where you have checked in this occasion arthroscopically that the fibula is reduced in the incisura using your C-arm at the same time. Now, if you have a malreduction of the ankle or the syndesmosis, and you have used syndesmosis screws, admit the problem and revise early. This is a high demand young patient who is in the special forces in the army, had an injury at work, and he was fixed like this, and he was still in a lot of pain. He was fixed in a different hospital. I came to Frimley Park when I was working in the UK, and even he was seen by a non-foot and ankle surgeon. He said, the patient is in a lot of pain. Could you please see him? And we did the CT scan that shows, yes, these little fragments within the joint. The posterior malleolus fracture is not reduced. The fibula is not really anatomically reduced in the syndesmosis, in the incisura, and there is slight displacement of the posterior malleolus fracture. But also the fibula is short and probably malrotated. So should we leave it as it is? Remove the loose fragments only, or wait till 10 weeks to remove the screws as well, or proceed to revision fixation? I think here you should do something for the non-anatomically reduced fibula, which is short and malrotated. That is essential. And this is not easy surgery. You fix the posterior malleolus, and once you bring the fibula out to length, the correct rotation, the fibula has reduced within the incisura, and this patient had a very good outcome. So this is the geometry of a normal ankle joint, these little like a Shenton line in the distal fibula. So you can look this up and check all your x-rays and see if you have reduced the fibula anatomically when you do your fracture reductions. This case was given to me by a colleague in Athens. He came across this patient who was originally fixed in another hospital, had an open fracture dislocation playing football. That was the reduction of the fibula, and a few days later he sought a second opinion, and my colleague did not even an EUA, he took the patient out of cast and did an X-ray with the image intensifier, really, and that's what's happening there. So we have a short fibula, malrotated, torn interosseous membrane and syndesmotic ligaments, and torn deltoid ligament that was an open injury on the medial side. So during the first surgery, they had removed that butterfly fragment from the fibula. He brought it out to length and checked the position of the fibula within the incisura. The way you can see with open reduction, took a picture because of that to show that exactly he had checked it. And you don't rely just on the AP view. We know X-rays or image intensifier views are unreliable in order to detect any displacement of the fibula in the incisura. And this patient went away and that was the final fixation. The patient went away, and a few years later he called him to see what's going on, and he said, well, I'm playing football again, never bothered about, we never know when the screws broke. He had the excellent outcome because the fibula was broke, because the fracture was fixed properly and the syndesmosis was stabilized. You see the new bone formation in the fibula. This was a young patient, good biology, and that was probably the reason why his syndesmotic ligaments healed with some scar tissue in the distal tibiofibular syndesmosis area, and that's why his ankle remained stable. The same applies to the deltoid ligament. My colleague did not repair the deltoid ligament. That's a slightly different case with a high BMI young patient who was of Chinese origin in the UK for an Erasmus program. He had an injury of his ankle. This one, posterior malleolus fracture. Our colleagues fixed the posterior malleolus, but did not fix the high fibular fracture. They just relied on syndesmosis fixation with these screws. But the fibula is short and probably malrotated, so it wasn't really anatomically reduced. The patient was scheduled for removal of screws. He ended up on somebody else's operating list, and a less experienced surgeon, not a consultant, was in the operating room. You see the knife there. He wanted to take the screws out with small incisions, and that's what was discovered intraoperatively with the patient under general anesthetic. Now, it doesn't reduce. We removed all the, I was called in. I asked for another colleague to have a look to confirm, because we didn't have consent from the patient was consented for screws removal, not for any reconstructive surgery. Still not reduced properly. We put an arthroscope in, cleared the medial side. Yes, then we could reduce it, and did that fixation, and he was due to leave the UK, go to Spain to carry on with his Erasmus program. I don't know what happened to the patient, but I would say ideally one should have done, if what was a sort of elective case, done a fibula lengthening osteotomy to get the fibula out to length and make sure the patient will not run into problems in the future. Osteotomies can be a solution. In this case, it was a 44 years old female teacher who said, I don't want an arthrodesis. I want to be able to wear high heel shoes. And she had a weak, unstable, and painful ankle 8 months after fixation of this fracture. So arthrodesis was an option. The patient didn't want it. She's too young, I would say, for any replacement. So we tried joint preserving surgery, doing an arthroscopic debridement and a distal tibial osteotomy. I was prepared to do a fibular osteotomy, but once the tibia was reduced and the alignment of the ankle was reduced, then there was no instability around the ankle. So the malunion was the problem, not any torn ligaments at the time. And this was the only X-ray taken to this patient a month after the surgery. I know this patient, she doesn't want another X-ray taken. For 9 years, she did not need any other intervention, and she's able to wear high heel shoes. And well, osteotomies do not always work, like in this 49 years old nurse who had an ankle fracture it was treated elsewhere with a syndesmosis screw that was removed, but she was unstable. I tried to salvage the ankle, but it did not work in this case. Or if you have a 79-year-old patient, according to her medical records, she had the deltoid repaired and syndesmosis fixation, then complicated by infection, screws were removed, ended up with arthritis. The only option is to salvage it with an arthroscopic arthrodesis, in this case, which is a very good salvaging procedure. And then you have a young patient with a plain valgus foot. I'm going towards the end of the presentation. He's on cortisone. He has a significant comorbidities, ends up like this. I don't think a deltoid ligament reconstruction and any fancy surgery is a good option for such a patient. And an arthroscopic arthrodesis using a hindfoot nail was the salvaging procedure. So to conclude, do a CT scan, fix what is fixable, and avoid syndesmosis screws if possible, checking the reduction of the syndesmosis open or arthroscopically or with an intraop CT. And if you have a problem, admit it and revise early to avoid an arthrodesis. Osteotomy might be an option, but usually you end up with fusing the joint. Thank you for your attention.
Thank you, Nikos, for wonderful presentation. You've shown us a lot and lots of examples and very clear messages, and I'm sure that will be interesting discussion, which we'll do in the end once our second speaker of tonight has given his talk. So let me welcome Professor Stefan Rammelt. He is head of the Foot and Ankle Service in Dresden and is also the vice president of the German Foot and Ankle Society. He's going to talk about his vast experience with the classification of the malleolar malunions and how to manage these. Over to you, Stefan. Thank you.
Thank you very much for the invitation. It's an honor to speak here. And I want to show the presentation. Can you all see it?
We can.
Yeah. Okay, so this is the little town I come from. It's a little smaller than London, but also lies on a nice river. These are my disclosures, not related to the next talk. The talk is slated to be about classification. So there is no real classification for ankle malunions. And it was only during the time of the pandemic that we had the time to think about it. And I like to keep it simple for the surgeon and for myself. And so I classified them for my practical work, just like the acute malleolar fractures, according to which malleolus is fractured. We already heard about the ring concept, and so the anterior and posterior syndesmotic avulsions working like malleoli, although they don't look like them. And so one of the basic laws in surgery is Murphy's law. Anything that can go wrong will at some point go wrong. And as you can see, fractures of all the four corners of the ankle or all the four malleoli, you can also see malunions. Then, of course, there are pilon malunions, there are supramalleolar malunions. I will not speak about them. That would lead us too far. So let's start with a simple case, and you have seen similar ones in the previous talk. This is a classic case, 45-year-old patient, ORIF. You can see maybe the medial side is a bit wide, maybe the fibula is not exactly out to length. She's still painful after 1 year. Then what is done? The German solution is hardware removal. This doesn't help, and then the patient was told nothing else can be done. But is that really true? Here you see the radiological landmarks. You see Weber's circle that is not hit by the tip of the fibula, which means the fibula is too short. You cannot always see the Shenton line of the ankle after a fracture, but the length can be easily seen, and you can see how the talus is slightly shifting laterally and is tilting. And you can also see that the syndesmotic clear space is a bit wide. So there is like a secondary syndesmotic insufficiency in those cases. And these are the principles of correction. I do not need to repeat this. We have to bring the fibula out to length. And if it is in a valgus position, we have to correct that. And so we did this in that case, and we shifted it down. You can really titrate this under fluoroscopy, so that in the end, the Weber circle fits again. And this is the same patient 8 years later. She came from another part of Germany, but sent me the X-ray and said that she is so far pain-free. And you can see the syndesmotic somehow stretches a bit when you do this lengthening of the fibula, if the osteotomy is above the syndesmosis. And René Marty, who worked with Hardy Weber quite some time, even sometimes had the feeling he had to loosen up the syndesmosis for this type of osteotomy. I try to avoid this because I want the fibers to be stretched out and to be really under a good tension again. And you can see this can work for quite some time. There are some series out of more than 10, 15 years without significant progression of arthritis and with very, very few secondary fusions. So this is the medial malleolus, which can be malunited. Here we see another female patient, 42 years old. 2 years after the injury, she already underwent 2 revisions for medial malleolar non-union. She was first fixed with screws, then with a plate, then finally it healed. But as you can see, it healed in varus. And that you can also see when looking at the patient from behind. You can see that the talus then shifts a bit forward. And here you can see the shortening of the medial malleolus. This was obviously a supination injury, which produces that vertical fracture of the medial malleolus. And now finally it healed, but not in the correct position. So when to correct it, we have to bring it down, and we have to get it out of varus, which means here we have to cut out that triangle that belonged to the former non-union. We didn't go to the lateral side because the fibula was not shifted. There was some kind of a plastic deformity, maybe a slight malrotation. We started with the medial malleolus and saw that the talus centered nicely below the tibia. And this is the patient 1 year after correction. The CT scan, you see how the talus shifts back, how the calcaneus shifts back, and the heel gets the natural physiological valgus position. And you can also see the correction of rotation of the medial malleolus. Most of these patients, if they have a plate on the medial side, they feel it. So we took it out, and she got quite some nice motion back. This is the function 2 years after the surgery and the scar formation. Now, of course, both the medial and the large malleolus can be malunited, like in this patient who had an easy Weber A fracture, but it was a stage 2. So again, the medial malleolus went up and went out. And in this case, also the lateral malleolus was healed in a malunited medial shift. And so that was what we saw on the medial side. There was already some wear of the cartilage at the medial talar dome. On the lateral side, we saw that large step off in the distal fibula. And so the correction osteotomy was exactly at the site of the malunion. And so the medial malleolus had to be lengthened, had to be shifted lateral, as had the lateral malleolus, which also needed a slight closing wedge osteotomy. This was the result after surgery. The patient who was not very compliant started walking on it and presented 4 weeks ago with pain. Luckily, everything was still in place, and this is him 2 years later with everything has healed and still at that point no progression of arthritis. Of course, also the posterior malleolus matters, not only for syndesmotic congruity, but also for stability of the ankle and of the joint surface. And this is even more important the larger the fragments are. So this is a 38-year-old female patient, persisting pain after trimalleolar fracture fixation. You can see the posterior malleolus was fixed in a classical way, indirectly from A to P with screws that were meant to be compression screws with partially threaded ones and cannulated ones. Then the German solution, taking the hardware out when the patient still has pain, but there was no improvement. And when you look at the Weber criteria, the fibula is definitely not too short. But if you look from the side, you can already see there's a large malunited posterior malleolar fracture. And you can see the step off in the radiograph, and you can even see it more so in the CT scan. Everybody in Germany that has ankle pain also gets an MRI for some reason. And here you can see how the loading of the anterior part, and particularly of the edge of that former fracture, affects the tibia. You see the bone marrow edema. You see the cartilage is still there, but it starts wearing out. So it's really time for action if you want to save that patient from a later arthritis and fusion. So this is the former fracture line, and we put the patient prone this time. The hardware was luckily out already, so it was good for one reason. And this is a poor man's navigation. You just put the K-wire in front of the side where you want the osteotomy, and then you work your way through with a chisel. Of course, you have to recreate that slightly curved former fracture, and then you bring it back. And of course, you have to turn the tube, the X-ray tube, to really make sure that there's no tilting of that fragment. And then in the end, it's fixed. And of course, it is stable because it's a large fragment that carries the posterior syndesmosis and the interosseous ligament. This patient too came from further away, but she kept sending me X-rays and was at that time absolutely pain-free. Now, of course, we have that anterior fragments, and as Nikos already showed, they can be smaller or larger syndesmotic avulsions, but they can be some kind of nasty fractures if they result from abduction injuries. So here you see a valgus deformity and pain after bimalleolar fracture fixation. Nothing was done to the anterior lateral part of the tibia. You see a slight valgus of the fibula, maybe some shortening if you consider the tibia, but not if you look at the Weber ball. And probably this is a result of pronation abduction type fracture, where the talus impinges on the distal tibia and produces some impaction there. And we looked at the pathoanatomy of these anterior fragments, and of course, the majority of them are avulsions, syndesmotic avulsions, which regularly result from rotational type of injuries. Then you can have that larger fragments that Nikos also already showed that are intra-articular, and they always also contribute to the incisura. So if those are malunited, then the fibula doesn't know where to go, and it takes that avulsed fragment with it, and this results in a malposition of the distal fibula, and it results in an insufficiency of the syndesmosis. And then we have that nasty type 3, which is anterolateral impaction of the tibial plafond, which is like a transitional type to a pilon fracture. And interestingly, when we analyzed them, we saw that the majority of those cases were initially pronation and abduction fractures. So here we probably have an overlooked impaction of the lateral tibial plafond, of the anterolateral only. And this patient didn't want a fusion, although you can easily see that this joint is far from being innocent. But we promised to try our best. So we did an osteotomy of the lateral tibial plafond through the fibula, and we shifted the fibula and that anterolateral fragment down, put some bone graft in both of these osteotomies, and we buttressed the anterior plafond with buttress plate, with an anterolateral plate. This is the patient 1 year later. She's not absolutely pain-free, but she can walk on even grounds without pain, has some limited dorsiflexion, doesn't do sports. So we took the fibula plate out. I didn't dare to take the tibial plate out and left it in because it is far away from the skin. And she comes from the northern flatlands of Germany and keeps sending me images every year. So she lets the horse do most of the work and her husband. But she has a beautiful function 7.5 years later. You see, of course, some anterior osteophytes, so the arthritis doesn't go away. But so far, the ankle joint has been saved for quite some years, which can be good in these patients. And finally, according to Murphy's law, all of the 4 malleoli can be in a malposition. Of course, also according to Murphy's law, this must be an orthopedic surgeon that was treated by his colleagues of his own clinic. He was unable to go back to work, and 4 months later, after that quadrimalleolar fracture, he presented with those images. And if you look at the CT scan, you can really see that all 4 malleoli are malunited. There is a malleus of the distal fibula, which is short and shifted anteriorly. The medial malleolus is malrotated. The posterior malleolus is too far down, creating a step off in the joint, and the anterior malleolus is broken off. And so the fibula doesn't know where to go, and the whole ring is broken in and malunited in all 4 corners. Here you can see the CT scan that shows that relatively shallow posterior fragment, but that shows how this old dogma of 1/3 or 1/4 is not valid. Also, a small fragment can lead to instability because the incisura is gone. It is taken away by the fibula, which is in addition here also avulsed with an anterior tibial fragment. And we went there and we corrected 3 of the 4 malleoli because we didn't dare going through that full thickness skin necrosis over the medial malleolus. So we went there, we put the posterior fragment back and supported it with a plate. We brought the anterior fragment back with a screw and a washer, and we added that syndesmotic screw, not because we felt it was really needed, but this is a malunion. This is not an acute fracture, so the bone is brittle, is a bit osteoporotic. So we added it like a tibia profibular screw, and of course the lateral malleolus was corrected. And for these chronic cases, maybe a hybrid fixation is not too bad. In this case, we just left that suture button implant that was already in on the top and probably not very effective there. We just put a smooth elevator between the medial malleolus and the talus and tried to push it back because we didn't want to go through that skin necrosis. Maybe it helped a little. Here you can see how the posterior and anterior fragments are brought back. This is a CT scan 6 weeks, which he sent us. And so hopefully he's doing better now. So in summary, all 4 of the malleoli can break and all 4 of them can malunite. And if so, this can rapidly lead to incongruity and arthritis of the ankle joint. And of course, osteotomies can help in those cases. And even if you buy your patients some time, particularly if they are young patients, then you have already won the game, because neither a fusion nor a total angle will be a permanent solution in a young patient. Address all 4 malleoli, correct as early as possible, because then it is number 1 easier, and number 2, hopefully the arthritis hasn't gone too far, and you can get really good long-term results if the patients are reliable, if there's still some reasonable bone stock and some cartilage. Of course, if the cartilage is gone over most of the joint, then you can even go straight on to a fusion, and you need, at least this time, exact realignment. And then you might see progression of arthritis, but it does not necessarily lead to symptoms. The ankle can take a lot, even if it doesn't look in a virgin state. And not all of the arthritis that you see on the X-ray really lead to symptoms and need later on a fusion. So thank you very much for your kind attention. And of course, I'm open to discussion.
Great talk. Thank you so much. So we will open up discussion. Thank you, Nikos, for bringing your screen on. So I've got a few questions from our audience. So first question is to you, Stefan. How do you decide when it is too late to do salvage surgery of this sort rather than doing fusion surgery? How do you decide? And is there any factor?
Yeah, so my rule of thumb is if the cartilage is gone or severely damaged over half of the joint or more, then it doesn't make sense reconstructing it anymore. The patients will still have pain. The talus will still be tilting because of that different height. If it's up to 1/3, so it's medial, it's basically the medial or the lateral talar dome that is affected, then it's astonishing how long those patients prevail without a secondary fusion. That is my personal experience, my rule of thumb. So you may say at Takakura stage 1 and 2, you can easily correct. If it's getting out, then it's probably too late. But of course, you also have to look at the patient and the residual function. If the ankle doesn't move, it's probably not worth trying to get it moving again, except if they're really large osteophytes that you can take off. And of course, the patient has to be reasonable and has to follow your instructions, your non-weight bearing instructions, but also then physical therapy to really benefit from the salvage of the joint. Otherwise, smart solutions for smart patients.
Yeah, no, sounds very reasonable. And that just brings me on to the next question automatically. Do you have a post-op regime for when you're correcting the malunion? Do you keep your patients non-weight bearing when you've fixed these fractures?
I typically try to do this on reasonable patients that can do a partial weight bearing, because the bone needs a signal to grow together. So you should at least put the leg to the ground with its own weight. 15, 20 kilograms, and the patient should also do early range of motion as soon as the wound has healed to really benefit from the joint preservation. And then it's typically, if it's a simple osteotomy, it's 6 weeks. If the bone stock is already bad, it's a bit longer. And if you need bone grafts for correction, then it's 10 to 12 weeks partial weight bearing. Then typically at that point, I see them back in the office. And if the bone has healed on X-ray, then we rapidly go on to full weight bearing.
Thank you very much. I just need to go through, there are quite a few questions, so I want to cover them all as much as possible. So the next question is in contrary to what we previously are. So how do you decide whether to revise a fixation if X-rays don't look great, but the patient doesn't complain of any pain? I'll ask you both, what are your views on bad looking X-rays, but no issues from the patients?
Then probably it is still early. So if I see a bad looking X-ray the day after surgery in the morning conference, I'll do something about it right away. And then hopefully the patient doesn't have symptoms from that. And so I would really go for it, because we all know that if it's 2 millimeters of shift, 2 millimeters of step off, then there will be problems down the line in a weight-bearing joint. Of course, if the patient doesn't have pain because it's neuropathic, that's a different story.
Thank you. Nikos?
Yes, I would agree. There are some mal reductions which are unacceptable. So if it's the day after surgery, you do not expect the patient to be in pain. So the patient cannot, if it's 4 or 5 months after surgery and the patient has started weight bearing and comes back, and it's or he comes for a second opinion or a routine follow-up appointment, there is no pain, I would hesitate to operate on an asymptomatic patient several months down the line. But if I see something that doesn't look right, like a fibula that's mal-reduced, not brought out to length, syndesmosis not reduced, then you should intervene early. So sometimes we have to treat the X-ray and not the patient's symptoms as early as possible in this case.
But to be honest, most of the patients come to me because they have pain in the ankle and a ton of MRIs and nobody knows what's going on and the X-ray looks bad. So I rarely see patients with bad X-rays and with malaligned X-rays. Let's say that, with malaligned X-rays. I see patients that have arthritis on X-ray, but with a malaligned ankle, they still cope for quite some time. And I think that is the message. So for them, you can still go preserve the joint instead of doing sacrifice.
So I would say, yes, Stefan showed one case where he has done osteotomy. I have a very good example of an osteotomy that I did. There is arthritis, but it was asymmetric arthritis, and the patients do well for many years. So you can preserve the native joint once it's, as long as.
Thank you. The other question is regarding incision choice from previous surgery. So somebody has used a lateral approach and obviously not addressed the posterior malleolus. Would you be happy to go through the new incision, or you try to use the same old lateral incision? Probably it's hard, isn't it? You need to go posterior, but I just wanted to hear from you. Would you go do a posterolateral approach and a previous lateral approach being done?
Absolutely, and you can even do a posterolateral and a lateral approach at the same time, as long as you stay parallel and have a reasonable distance between the two approaches. And also I see that question, so some people try to not fix the posterior malleolus because they want to avoid a posterolateral approach. We looked up our cases and we did not see more infections or wound issues with the posterior approach as opposed to a lateral approach. In contrast, you have less reasons to take the implants out because patients don't feel them, they don't bother them. You have a nice cover through the FHL muscle, which is there, and you have a stronger buttress when fixing them directly from the better reduction, stronger buttress. And even for the fibula, if you fix the fibula through the same approach, you have an anti-glide plate from behind, which is stronger than a lateral neutralization plate. So for me, there's no reason to avoid the posterolateral approach. Of course, you have to take care of the wound, and you have to avoid that the patient, when he's lying on his back, is also lying on his wound. So put some cushion beneath the calf, that the ankle, that the foot is really free, and avoid direct pressure on the wound, which could lead to problems. But it's not the approach itself that is to blame.
I agree 100%. And all the problems of the audience, all the problems we have seen with wounds around ankle fractures is where you see the fibula plate sticking out the wound when it's a direct lateral. With the posterolateral approach, the skin is much better there, usually not as badly affected by the injury as well. And it's a lot.
Thank you. Tips regarding the use of syndesmosis clamp. Could it cause malposition when reducing syndesmosis?
Of course it can. So I try to put it exactly along the axis of the ankle joint, which is from the tip of the medial malleolus to the tip of the lateral malleolus, if possible, if the fracture or fixation allows it. But typically it is after fixation of all malleoli. And then this clamp also gives you the direction for the syndesmotic screw or dynamic implant or whatever you want to have. And if that clamp is a bit off, then of course you can malreduce the fibula with the clamp. And also you have to have a look at the bony anatomy of the incisura. It can be retroverted, can be anteverted, it can be shallow, it can be deep. So all this has to be taken into account before reducing it, and then you can quite reliably avoid malreduction. Apart from what Nikos already said, go open, see the alignment with your eyes, use a scope if you want, if you're sure.
Well, it seems we
Nicholas?
have lost Stefan for a while. Yeah. So I would say yes. Syndesmosis malreduction can be associated with wrong positioning of the clamp, so you have to be careful. And that's there are also some studies that have shown that you can have up to 30 to 50% malreduction of the syndesmosis if you do a CT scan post-op. However, that's why I say try to avoid using syndesmosis screws. And especially you will see the problem with malreduced fibular fractures when you try to hold the whole construct with the syndesmosis screws. Then I'm sure you can't reduce that syndesmosis if the fibula is short, malaligned. There are all sorts of problems there. So sometimes the reason you put the screws in the wrong place is because the fibula is in the wrong.
Thank you. Stefan, audience, for a quadrimalleolar fracture, what's your fixation order?
I almost always start with the posterior malleolus, patient in a prone position. That already helps with reduction. And as long as there are no other implants, this also gives you a nice read of the lateral view in the fluoroscopy to really see that you did a good job reducing the posterior malleolus. And then the posterior incisura is already corrected. Typically, the posterior fragment is larger than the anterior one, and this helps with fibula reduction. So then you have recreated the incisura from the back. You reduce the fibula, mostly through the same posterolateral approach with the posterior plate. Then the medial malleolus, and then I slightly bend the knee, or an assistant does it, or just put a bolster underneath the leg. And with a small anterolateral incision, I fix the anterior syndesmotic avulsion of the anterior malleolus. So that's my typical fixation. It is a bit different if you have what we call a quadrimalleolar equivalent, which is a fracture of the Wagstaff fragment. Then I do this at the same time I fix the fibula, because when I fix the fibula from the back, you can have very long, nice screws, but they can push the Wechsler fragment even further out or hamper reduction. So I do a small incision anterolaterally and put a reduction clamp from the posterior to the anterior margin of the fibula to make sure the Wechsler fragment is in place, and then I can fix it from behind, can fix it from the front, or both, to make sure that everything is in a nice place. But most of the time I really start with the postermalleolus, because what you see more often than not, if people do the medial lateral malleolus, then they try to fix the postermalleolus from the front. You do not even see a step off because there's already a plate on the fibula and screws in the tibia. So you stop guessing when you start with the postermalleolus.
Nikos, do you have anything to add?
The only indication for an AP screw I find is when you put a nail for a tibia fracture and your posterior malleolus opens up. Then it has happened to me twice in 14 years. So then, yes, I had to put it, but that's a low energy injury. Let's put it this way. That's the only indication. I agree. Once you reduce the posterior malleolus, suddenly your ankle stops dislocating. You can see it. Then it's stable. Then everything becomes easy. For me, that's the key.
Thank you. There's another interesting question. How about adding inframallular correction on the medial side? So medial slide osteotomy for deltoid and syndesmosis disruption, malunion, or malrotation. Question to both of you.
So inframalleolar would mean talus or calcaneus. I do this in cases where it's typically not a malunited ankle fracture. It's that chronic instability where the talus works its way towards the medial malleolus and towards the medial tibial plafond. And sometimes it even creates a deformity and the lateral side goes unstable. And when you do weight-bearing films, you see that the tibial plafond is not in varus. It's straight. Maybe there's just a dimple on the medial side, but the talus tilts and the calcaneus, of course, goes with it. In those cases, I do the correction where the deformity is below the malleoli at the calcaneus level. And then I do that Korean-style osteotomy, so oblique osteotomy, supramalleolally, to close the ankle mortise and to gain some stability. Still, the X-ray will look weird after that because the cartilage has worn on the medial side and it will not be restored by that procedure. But if the deformity is really in the submalleolar level, then of course you have to correct there.
I have no personal experience of an inframalleolar osteotomy on the medial side, but I agree the concept and the rationale is correct of what Stefan just.
I think what they're asking is, sometimes you get deltoid injury and you get valgus deformity. So they are saying that, can you do a calcaneal osteotomy? That's what I get, to do a medial side calcaneal osteotomy if they've got a valgus deformity due to deltoid injury.
I watch out for them. But I rarely see that after malleolar fractures. It can happen in flat feet, in a severe stage 4 flat foot, but I have yet to really see that in a malleolar fracture. So the valgus deformity typically the culprit is the fibula. If the ankle goes into valgus and then the talus shifts over, and then typically the correction is at the level of the lateral malleolus, and then the medial side closes. And of course, if it's a long-standing deformity, you have to clear it out on the medial side, arthroscopically or open, and then the talus will come back.
Thank you.
I agree.
Another one we have. Yes. Yeah. Good. Nikos, this is a question directed to you. So there is no fracture and patient had an MRI scan and it shows that the anti-inferior tibiofibular ligament is disrupted, interosseous membrane is damaged as well, and there's possibly a sprain of the posterior tibiofibular ligament. You do weight-bearing X-rays, the ankle mortise is intact, but there is a little bit less overlap between tibia and fibula, or hardly any overlap. What would you do in these situations?
So, well, that was not the topic of this talk because that was syndesmosis disruption associated with ankle fracture. Here we talk about, this question is about a severe high ankle sprain. So I have not seen one where I should, let's say, fix it acutely. If I have a patient who is in a lot of pain after an ankle sprain, I'm suspicious of a high ankle sprain, and I treat these patients non-weight bearing in a boot for a bit longer and watch them carefully, do an MRI scan at around 6 weeks, and then I decide. Usually by that time the symptoms have reduced a lot. So it's a different topic. Yes, there are some rules. You do arthroscopy to assess them, and if the syndesmosis is really unstable, you can stick the scope in, which is about 4 millimeters wide. Then that's an indication for fixation of the syndesmosis with screws or tight rope. But that's a different topic, I would say. It's not. We have to start from the beginning, not to confuse us with what we said today. Now, that topic was syndesmosis injury associated with ankle fractures. So
that's fine. Last question. I'll try to summarize 2 questions. So 2 people have asked similar things. So one of the question is that should we be fixing posteromalleolar fractures in older or frail patients? And the second person who asked that if patient has got lots of comorbidities such as poor vascularity, neuropath, poorly controlled diabetes, does your treatment plan changes? So both of you can start. Nikos, you can start first for both of these questions. Old patients, posteromalleolar fracture, and neuropath or vasculopath.
So if it's a geriatric patient with a fracture dislocation, I would consider primary hindfoot nail fixation for the fracture. So the same way we treat hip fractures, just to get the patient up and moving. So put the nail for the patient to start weight bearing if it's an 85 or 90 years old. This is a consideration for these patients. If the patient is suitable, or if the skin is very bad, etc. So if the patient is suitable for open reduction internal fixation, I would do the same. If the bone is osteoporotic, I would consider, and if you put a fibula plate, put in lots of screws from the fibula to the tibia for better fixation for purchase. So use more metal, stronger construct in diabetics. So it's 2 different things. Is the patient suitable for open reduction internal fixation? Can they cope with postoperative? Is it worth coping with postoperative non-weight bearing status, etc.? Yes, you do open reduction internal fixation in the same way. If not, do an.
I would say the same. It's not about age, it's about the health of the patient. So the comorbidities are those who define the prognosis and also define your approach. So if it's an 80-year-old who wants to hike with the grandchildren, I would do the same as for a 20-year-old. If it's a 70-year-old diabetic with neuropathy, I would go for a hindfoot nail and hope he gets at least a fibrous non-union that he can walk on with a orthopedic boot. So it is really the comorbidities that dictate what you are doing. And of course, if they are bedridden and if they're not able to comply with anything, then you should consider those measures. Doing nothing, I don't think it's a good option. Those people don't do well in a cast. They will get ulcers. They will get thrombosis. So you have to do something, and it's I think it's dictated by the functional demand of the patient and its comorbidities.
Yeah, no, thank you. No, I get the message. I think the person who has asked this question has taken into consideration AIM trial. We had in UK ankle injury management trial 60 years or above, and open reduction internal fixation versus 12 total the cast, the molded cast for a 3-point fixation. And the results of that trial, they came, and the results were not dissimilar. Clinical results were not dissimilar. Having said that, radiological results were different. But I think it's very crystal clear from your talks that if you can, then you should go for anatomic reduction, and that sorts out or takes away the issues which we later see with malunion. So do it right
Even
in the first place is the message both of you have given.
Particularly in osteoporotic fractures, if otherwise patients are healthy, then with posterior plating, you can get a lot more stability and get the patients back. So according to this trial, in 5 years from now, nobody would fix my ankle. I would not like that.
I get it. I was thinking whether to ask the question, but anyway, questions are there to be answered, and I think it's important that you've given the message to our audience who have really enjoyed. There are lots of messages saying that the talks were great. Thank you very much. It was a great session, and I'm sure we'll receive formal written feedback as well. So thanks everyone for joining us. We are going to put this session to an end. I would like Stefan and Nikos and the BOFAS IT team to stay back, so we'll just have a catch up. But good night, everyone else, and we'll see you for the next Master Techniques session very soon. Thank you.